Hi, this is Dr. Sherpanini again. Topic for today is urinary tract infection. A urinary tract infection involves cystitis and acute pyelonephritis. Cystitis refers to bladder cavity and pyelo refers to kidneys. This can be both inflammation or infection. When you think about risks for urinary tract infections, we can hone in on three major risks, which is female gender, their anatomical predisposition, that is having a short urethra proximal to the anus. Lastly, lifestyle choices such as frequent intercourse, poor hydration, tendency to voiding regularly. Additional risk factors for urinary tract infections can include nerve damage from strokes, spinal injury, conditions like diabetes, use of condoms with spermicidal foam, diaphragms for birth control, menopause, family history, kidney stones, BPH in men, catheter use for draining the bladder. Some symptoms associated with urinary tract infections can include burning, urgency, frequency, pain, pressure, with voiding. When associated with fevers, flank pain, or back pain, it is suggestive of acute pyelonephritis, in other words, a kidney infection. Please note, blood in the urine is more common with kidney stones. When a patient is displaying symptoms of a urinary tract infection, treating them empirically is not always recommended. Ideally, a patient should undergo testing with a urine analysis or dipstick and microscopy along with the urine culture. A general criteria that's commonly used in clinical practice to diagnose a urinary tract infection is to look for clinical symptoms and abnormal findings on a urine analysis along with positive urine culture. A urine analysis includes dipstick and microscope evaluation. A dipstick really has 10 components that we can check: a pH, specific gravity, protein, glucose, ketones, bilirubin, urobilinogen, leukoesterase, nitrites, blood. Under a microscope, a doctor can see your white blood cell count, red blood cells, bacteria, yeast, cas, and crystals. A basic interpretation of urinary analysis includes looking for a positive leukoesterase along with the positive nitrites. This combination of positivity should imply a strong likelihood of a UTI, and thereafter a urine culture should be checked. You must note that a urine sample with a negative nitrite can happen despite of having bacteria, because not all bacteria can convert nitrates to nitrites. And a positive leukoesterase, along with findings of elevated white blood cells under microscopy, should still suggest a UTI, and a urine culture should be sought. Other interesting takeaways from urine analysis is looking at a person's specific gravity, which can suggest a person's hydration status, and any elevation urobilinogen or bilirubin can indicate liver disease. Generally, when one looks under a microscope, we see white blood cells, red blood cells, cas, crystals, epithelial cells, bacteria, yeast. An elevated white blood cell along with leukoesterase can be suggestive of a UTI. Now, when correlated with the culture, if you had a negative culture, it is suggestive of STDs like chlamydia, gonorrhea. Other findings on a microscope include elevated red blood cells, which is microscopic hematuria, as seen in urinary tract infections. You can also detect cas, which imply kidney disease. You can detect crystals, which imply kidney stones, and you can also find bacteria, yeast. Lastly, elevated epithelial cells, which is usually a sign of contamination. Imaging can play a role in evaluation of urinary tract infections, especially when we suspect kidney infections. We can utilize imaging from ultrasounds, MRIs, and even CAT scans to better diagnose a kidney infection. If you're suspecting kidney stones, we often recommend CAT scan without contrast to identify kidney stones. Other studies like voiding cystourethrogram can be ordered by a doctor to study if a patient's UTI is due to a vesicourethral reflux. In other words, basically urine refluxing back up from bladder into the kidneys. This can be done by injecting a dye into the bladder through a catheter and taking pictures of the urinary system. Some common bacteria that are implicated in urinary tract infections include E. coli, Klebsiella, Pseudomonas, Enterococcus. And fungus like Candida can also be identified in patients with urinary tract infections. This is more common in patients who reside in nursing homes and long-term care facilities. Just keep in mind, when treating patients for UTIs, we treat patients differently depending on their gender. For women in an ambulatory setting for an uncomplicated infection, we can certainly give them antibiotics for a short duration, like 3 to 5 days. As opposed to men, they need testing before treatment can be initiated due to increased risk of complicated infections from prostate or STDs. Again, to reinforce my message, complicated infections in men and complicated infections among the high-risk population, like those who have diabetes or who live in long-term care facilities or who have memory loss like dementia, or who have a chronic indwelling catheter, have to be cared for with more precautions like fluids and testing. Other high-risk groups include patients who are undergoing urological procedures, who are planning to go through prostatectomy, or who are post-operative and have been recovering from any urological procedures, patients who have, again, indwelling catheters, patients who are high risk due to chronic comorbid conditions like chronic kidney disease, or who have undergone renal transplant. Some key concepts to remember are that limiting the duration of antibiotics to 5 days for female patients in the outpatient setting and about 7 to 14 days for men in the outpatient setting. Always do testing with men because of their risk for complicated infections from prostate or sexually transmitted diseases. Some strategies a patient should use to prevent UTIs include voiding after intercourse, scheduled voiding, drinking plenty of fluids, daily intake of yogurt, or supplementing their diet with probiotics. In a patient who has a chronic indwelling catheter, make sure the catheter is replaced.